Okay, so sorry for the technical problems that led to the sudden interruption of the first video, but this is the second part of the part two of our lecture. So we continuing about chronic tubular interstitial nephritis. This one, as compared to the acute one, has a much longer period of developing pathologic changes in the tubules in the interstitium. Again, medications and toxins are still the most common cause, particularly in developed countries. Prolonged NSAID use, lithium, calcineurin inhibitors like cyclosporine and tacrolimus are very common causes as well. Herbal medications, no, the aristolochic acid, uh, are previously a very common culprit among these cases. Chemotherapeutic agents such as cisplatin and nitrosurias are also um, associated with chronic tubular interstitial nephritis. Um, Chronic hypokalemia. So in patients with disease states associated with long-standing hypokalemia can cause vacuolar changes, no, in the tubular cells that can also lead to tubular interstitial nephritis. Hypercalcemia, hyperuricemia, and hyperoxaluria are also the other metabolic disorders associated with CTIN. Chronic urinary tract obstruction, vesicoureteral reflux, especially among the pediatric age group, um, sickle cell disease, Sjogren's disease, SLE, and certain chronic infections like recurrent UTIs and tuberculosis, HIV, multiple myeloma, are other causes of CTIN. So it has this regardless of the cause, there is an initial insult that causes immune injury and direct tubular cell damage. This would lead to the infiltration of the lymphocytes, macrophages, and plasma cells, eventually leading to fibroblast activation that would increase extracellular matrix proteins in the tubular interstitial area, leading to eventual fibrosis or scarring, tubular atrophy, and also vascular changes, leading to a progressive nephron loss, leading to chronic kidney disease. So it is a slowly progressive type of disease that is only manifest in symptoms if the chronic kidney disease is already advanced, such as, and the symptoms are also non-specific, fatigue, weakness, mild flat discomfort, dizziness. So the same manifestations as chronic kidney disease. On laboratory findings, it could present with nocturia, polyuria, renal tubular acidosis, hyponatremia, hyperkalemia, and hypophosphatemia. It can also present with mild proteinuria and microscopic hematuria on urinalysis. So, as renal ultrasound can manifest as small echogenic kidneys, particularly in late stages, but it could still be normal size, no, in early stages. But there's already a loss of the distinction of the cortex and the medulla, and it may show nephrocalcinosis, stones, or papillary necrosis. So, while renal biopsy is not necessary, it can show chronic interstitial inflammation, fibrosis, tubular atrophy. And in terms of management, we have to remove the inciting agent similar to the acute tubular interstitial nephritis. If there's obstruction, you have to relieve that obstruction, either by medical or by surgical means. Managing the metabolic abnormalities like potassium supplementation, use of bisphosphonates, no, in hypercalcemia, and giving allopurinol or febuxostat if hyperuricemia is present. Other management measures that I mentioned in chronic kidney disease, the reduction of blood pressure, use of ACE inhibitors and ARBs, glucose control if diabetic, dietary modifications, and avoiding nephrotoxins are also the other um, management options that we can give to this patient. So finally, the third type of AKI etiology is post-renal. So these are obstructions after once the kidney produces the urine and going into the urinary tract. So it could be blood clot, foreign body, kidney stone, um, other abdominal pathologies such as intra-abdominal adhesions or retroperitoneal fibrosis, prostate cancer, and other malignant tumors or masses. What is common is there is decreased urine flow across the point of obstruction, leading to the buildup of the urine, okay? And would have decreased urine output as well. And while while obstruction can be relieved, it could cause a rapid increase in the GFR and rapid diuresis, which may also cause um, post-obstructive diuresis that could lead to hypovolemia or electrolyte abnormality. So we have to be very careful in managing post-renal or any obstructions that cause the post-renal acute kidney injury. So one of the common causes, other than benign prostatic hypertrophy, is nephrolithiasis. So there are different kinds, but this is the five most common types of kidney stones. The most common, even in the Philippines, is calcium oxalate. Um, it's a radio opaque because of the calcium component of it. Again, di ba yung calcium oxalate has the envelope-shaped urine crystals that I mentioned in the first part. It's usually common in the the adult males. Yung calcium phosphate, less common, still radio opaque, but this is usually associated for those individuals with primary hyperthyroidism and distal renal tubular acidosis. For those with gout or other metabolic non-communicable diseases, yan, uric acid stone, very common also in our country. So among these patients with especially with the tophi already, um you might suspend the patient would have symptoms referable to a kidney stone. Uric acid might be the primary type of kidney stone for that individual. Struvite is associated with the urea splitting bacteria, and I mentioned the coffin lid crystal in urinalysis. And finally, the cysteine, which is the hexagonal type of crystal that you can see in the urine urinalysis as well. So, in addition to those factors, no, so heat, water loss, and sweating are very important determinants. That's why nephrolithiasis has a very high incidence and prevalence in our country. Diet plays an important role, especially if it's high sodium and high protein intake, which leads to a more acidic urine. And most of these kidney stones grow in an acidic environment or an acidic pH. They're kidney disease related, na yung mga medullary sponge kidney, polycystic kidney disease, the horseshoe kidney, and other metabolic disorders as well. So what happens? So if there's a risk factor, whether it's genetic or diet, there is an increased urinary supersaturation. There is hyperoxaluria. Oxalate is a it promotes stone formation. Increased calcium in the urine also promotes stone formation. Low urine volume, so therefore the crystals and the other solutes tend to be less fluid and less saturated, so therefore they have the tendency to clump together. And yung acidic pH as well. So there is the nucleation or the aggregation of these crystals or these solutes, causing it to grow, further aggregation, and there would be a crystal cell interaction, which would lodge no in the the Bartolini cells, so in the renal collecting duct, and eventually will grow in size, leading to a stone formation. So these are the common symptoms, particularly yung flank pain, usually unilateral or one side, painful urination. If it is complicated with urinary tract infection, it could be cloudy or has a foul-smelling urine. It would also present whether it's gross or microscopic hematuria. In complicated cases, it could be associated with nausea and vomiting, fever and chills, and difficulty passing in urine if there is already significant obstruction. So, in terms of imaging, um, one can still use the plain kidney ureter bladder radiogram. So, but this would be limited to those radio-opaque stones, such as this one, a very small stone at the left kidney. This one, if you can see, there's some branching. So the stone size here is definitely much bigger than this one. And this is what you would call a staghorn calculi, because it looks like the horn of a deer. So it branches out, and it follows the shape of the calyx of the kidneys. So this would cause significant obstruction and definitely would need a more aggressive type of management more than medications. Sonogram is now the primary diagnostic tool used. So as you will see here, there is increased echogenicity or more a white sheen appearance. As you can, it's an ovoid shape. But what would distinguish it, since there are this is the kidney, and you would notice that in the normal structure or architecture, there's still that echogenicity that bounces off. But what makes the stone different is that there's this acoustic shadowing, meaning there is a bouncing back of the waves, no, the sound waves from the sonogram, from the stone going back top, and it doesn't penetrate down, unlike the other normal parts of the kidney or even the other parts of the body. And you would also see here in another view a very intense echogenicity with, again, this shadowing here, which would signify the presence of a kidney stone. So CT stonogram would be helpful if there is signs of obstruction or other complications, because there will be 10 to 15% of kidney stones that might be missed, especially if they're very small. Um, this the intensity of these stones can be measured by Hounsfield units. So those Hounsfield a particular type of kidney stone, for example, would have a range of Hounsfield units. So obviously, the higher it is, it's the intensity or the whiteness of the kidney stone is increased. So usually the calcium stones, the calcium oxalate and the calcium phosphate would have higher, like more than 1,000 Hounsfield units. Yung uric acid stones would have the lowest one, which is usually about 50 to 200 Hounsfield units. So what are the interventions that we can do? So definitely we have to address low urine volume, increase fluid intake. But actually you don't have the better recommendation is not to have a fixed intake, but more of a urine output guided um, fluid intake, wherein you should at least have a urine output of 1.5 to 2 liters per day. So that would allow increase in urine volume, avoiding further growth of the kidney stone, and at the same time, the possibility of um, dissolving the stone in the kidney. Obesity, so dietary modifications will be very important, low in protein, low in salt, high in potassium. If you can also measure yung certain urine parameters like calcium urine excretion, citrate urine excretion. Citrate is a stone inhibitor that's also normally found in our body. So if there is hypositraturia, definitely less inhibitors, it promotes stone formation. So we usually give also potassium citrate as part of the treatment for dissolution. High calcium, but while most stones are still commonly calcium type, you don't have to restrict the calcium intake. So maintain the usual calcium intake. That would be still very important. What would be restricted now would be the animal protein intake. And then if the uric acid is the primary type of kidney stone, you give urate lowering agents such as allopurinol and febuxostat. Um, most potassium citrate is also given to alkalinize the urine, which would promote dissolution of the stones and avoid further growth of the kidney stone if already existing. Um, if there's complications of UTI, give antibiotics which can be based with the local antibiogram. Okay. How about simple renal cyst? So, well, it's a very common incidence which doesn't have any significant health complications or not even, it doesn't even commonly lead to chronic kidney disease or renal dysfunction. So, there are benign fluid sacs in the parenchyma with a thin wall, no septations or solid components inside. So it's common as we age. No? So for 40 years old and above, it's usually about 20%, and it goes high up to 50% in the elderly, 70 years old and above. More common in males, but the exact cause of it is still unknown. There are some theories such as tubular obstruction that leads to the dilatation of these sacs, and there could be a diverticular formation and age-related changes also in the tubular structure. Most renal cysts are asymptomatic. They're only incidentally discovered on ultrasound or imaging. It does not cause also hypertension as well. In rare cases, it could present as flank or abdominal pain, hematuria if the cyst fractured, and it could be palpable mass if it grow into a significantly large size. It could lead to hemorrhage, infection, rupture, which is although rare, and obstruction as well. So ultrasound is the most common imaging, and you can use also CT scan so that you can classify if you think that the cyst would be a little bit complicated or large in size. So Bosniak one would be the simple one, meaning there is no malignancy risk. And going up here would be the most severe would be Bosniak 4, which is most likely or favorably so, there's a high probability of malignancy that might require surgical removal because it could be due to a indicative of a presence of renal cell carcinoma. So usually no treatment is needed, especially for the simple cyst. But if it is symptomatic, you can do percutaneous aspiration, sclerotherapy, so that the cyst could shrink in size, laparoscopic decortication, and open surgical excision. Now, in contrast, yung autosomal dominant polycystic kidney disease, which is also an inherited type of disease, is a progressive development of multiple bilateral renal cysts that leads to the enlargement of the kidneys and eventual kidney failure. So this is a common chronic kidney disease that is inherited. Um, the prevalence would be around 1 to 1,000 live births. And then there's equal male and female distribution here. There are two genetic forms, the PKD1, which is chromosome 16, and PKD2, which is in chromosome 4. In 16p, so the short arm in PKD1, PKD2 is in the long arm or the 4q chromosome. Most cases would be the PKD1. The chromosome encodes the polycystin-1 protein, and it has more severe disease that leads to progressive decline to end-stage renal disease. The second one would be a milder one, and it would be a later onset chronic kidney disease, around 70 years old and above. So extrarenal manifestations are also common in autosomal dominant uh, polycystic kidney disease. Early on, ADPKD can be asymptomatic, but if it became enlarged, it could present with pain, which is the most common symptom. Kidney stones could be present in 20% of the cases. Hematuria, urinary tract infection, um, elevated blood pressure in more than half of the patients, mild proteinuria, and it could lead to also chronic kidney disease, cardiovascular disease, intracranial aneurysms, and they sometimes also would have multiple hepatic cysts as well. So polycystic liver disease. So ultrasound would be the screening tool of choice. So the definition of polycystic would depend on age. So from 15 years old to 39 years old, if there is more than 3 cysts in one or both kidneys, that's polycystic. For 40 to 59 years old, 2 or more cysts in each kidney would the minimum requirement. And for 60 years old and above, more than or equal to 4 cysts in each kidney. CT scan and MRI can be used also in order to measure the total kidney volume, because that would predict the progression rate to end-stage renal disease and for prognostication of these patients. Genetic testing is not routinely required because it won't change the way you treat these patients. It's but more of for indicated for young potential living donors and those without any family history but suspected autosomal dominant polycystic kidney disease. So, the most common abnormality besides elevated creatinine would be elevated uric acid. Hematuria and proteinuria can be present, although milder in intensity. So for treatment, there's really no cure for autosomal dominant polycystic kidney disease. The most important would be blood pressure control, targeting a BP of less than 110/75. Again, the first line agents would be ACE inhibitors or ARBs. You can also give vasopressin B2 receptor agonist, tolvaptan, because the studies have shown functional decline would be slower in individuals who took tolvaptan as compared to those who are not, because it decreases fluid secretion into the cyst and it slows down the growth of the cyst. But you have to be cautious that it's only given up to the CKD stage G4. So that is about 20 ml per minute. So if the eGFR or the estimated glomerular filtration rate is lower than that, tolvaptan becomes contraindicated. So lifestyle and dietary modifications is important. If there are complications such as pain, hematuria, urinary tract infection, it should be treated as accordingly. So now, going back to the acute kidney injury, as I mentioned, it's a pre-renal. So hypovolemia, as I mentioned earlier in the first lecture, importante yung ano, no, the pulse increment, meaning there is a significant increase in the heart rate of more than 30 from sitting to standing position. There is postural hypotension or change or a drop in the blood pressure on standing. Dry axilla is, as I mentioned, yung axilla would be a good marker of the presence of good extracellular fluid, change in sensorium or confusion. And as I mentioned, these are not reliable indicators. So for blood loss, again, the same, pulse increment of more than 30 beats per minute and severe postural dizziness. And depending on the estimated blood loss, there would be gradually increasing tachycardia, lowering of the blood pressure. They could also lead to tachypnea as well and change or worsening of the mental status and oliguria and anuria as well. So for diagnostic findings, so these are the differences. So pre-renal, usually there's no red blood cell or white blood cell cast because this is usually relatively milder at the onset. A very important marker would be the fractional excretion of sodium. The computation would be urine sodium times serum creatinine divided by urine creatinine times serum sodium. So if the ratio is less than 1, that means that the kidney's ability to reabsorb sodium is still intact. However, in intrinsic AKI, wherein there's already a tubular dysfunction and there's an inability or limited ability for the sodium reabsorption, so higher urine sodium ang content, so therefore you would expect a higher number or value of the fractional excretion of sodium. And then the BUN creatinine ratio, okay, would be also in good indicators and a urine specific gravity also. In terms of management, okay, so for those at risk, if possible, discontinue a nephrotoxic agent, ensure good hydration, good volume status. If in cases hemodynamic monitoring is important, some commonly uses now certain echocardiogram parameters or using Doppler ultrasound to check for the hemodynamic status of the patient. Monitor serum creatinine and urine output, definitely, because that's the markers for kidney function. You avoid hyperglycemia, especially for diabetics, and consider alternatives to radio contrast procedures. As we go along, so you would consider already diagnostic workup if there is already presence of even the mild form of acute kidney injury, adjust the drugs if it's needed depending on the estimated GFR, and the more severe it goes, you have to consider dialysis already or admission to the intensive care unit. So sa sepsis, very important yung the standard of care, the sepsis bundle that they call. So getting the blood cultures, monitoring the urine output, adequate IV hydration, and antibiotic management. Some would also measure the serum lactate and the hemoglobin levels of the patient at the start. Toxins, definitely avoid or stop those nephrotoxins, optimize blood pressure, and prevent harm. Fluid replacement would be very important, especially if there is fluid loss or blood loss. So for fluids, I mentioned here already on the first lecture, yung balanced crystalloids or crystalloid IV fluids. For replacement, still the same. For routine maintenance, you can go in the IV fluids with much lower sodium content. So if there's no hemorrhagic shock, you can use isotonic crystalloids rather than colloids because there's studies that have been shown its superiority over the crystalloids, and its cost effectiveness is not well established, especially in our setting. Vasopressors can be used, especially if it would be very difficult to infuse significant amount of crystalloids or IV fluid for that individual, particularly for elderly or for those with heart failure. Hemodynamic and oxygenation parameters are advised, no, to monitor the development if the acute kidney injury is worsening or if there is improvement. So critically ill, of course, the management of the blood sugar, the total caloric energy intake, and um, the usual, no, the normal protein intake, recommended protein intake for these individuals. Again, prefer the oral enteral route when giving nutrition rather than the intravenous or parenteral type of feeding. For contrast-induced nephropathy, I mentioned this one, using the lowest possible dose and using the iso-osmolar or low osmolar iodinated contrast media. And then yung IV fluid expansion with isotonic sodium chloride or sodium bicarbonate. I mentioned N-acetylcysteine prior to the procedure. Theophylline has not been proven to prevent contrast-induced nephropathy, as well as phenoltopam. So, regardless of the cause of the AKI, these are some of the indications for renal replacement therapy, whether it's peritoneal dialysis or hemodialysis. This would be very important, which is also similar to the indications of chronic kidney disease. But a very important difference here would be the poisoning or intoxication. But for the other conditions or the other indications, they're pretty much the same indications as chronic kidney disease. So urinary tract infection, again, a very common type of infection locally. In the extremes of ages, it's much more common in males. For the neonates or infant male, it's much common because the genitalia is still relatively underdeveloped. For the elderly, it's because of the increasing frequency or prevalence of the benign prostatic hypertrophy, which makes them predisposed to urinary tract infection. But in the middle of it, females would be much more common because of the close proximity with the the rectal anal area and the genitourinary area. So, but we have to, in terms of pathophysiology, there's an interplay of these three factors: the host factors, the environmental factors, especially if the patient has foreign foreign body like a urine catheter, or there's any pathologic problem that causes anatomy and urinary retention, and the microbial factors also. So the type of organism. Escherichia coli is still the most common etiology of UTI, even in the most complicated types of urinary tract infection. So How to approach urinary tract infection. So the 2013 guidelines give us, since it's a majority female, no, especially in the adult population, so they give us this a very simplified algorithm to in order to treat these individuals with UTI. But it's very important yung presence of symptoms, dysuria, frequency, urgency, hematuria, and discomfort in the lower abdomen. So if the female has one of these symptoms, the first consideration would be, is the patient pregnant? So if yes, uh, we won't discuss the treatment in uterine pregnancy. That would probably be for the OB/GYN department. Is it recurrent? It happens more than twice a year. So we will discuss that. Are there any risk factors for complicated UTI? We will discuss that, complicated UTI. But if none, is there presence of flank pain or fever? So it could be a pyelonephritis. We will discuss that. If there's no flank pain or fever, does the patient have vaginal discharge? So it could probably be not UTI, but more of a sexually transmitted infection. So unfortunately, we won't discuss that. And then if none, most likely the patient has an acute uncomplicated cystitis. And that also will be discussed, starting with recurrent UTI. So the definition of recurrent UTI is healthy, non-pregnant woman with known urinary tract abnormalities with 3 or more episodes of acute uncomplicated cystitis documented by culture during a 1-year period or 2 or more episodes in half a year. So it could be relapse or a reinfection. Yung relapse is the initial organism persists and reemerges despite a adequate treatment. And that in the episode again happened 1 to 2 weeks after the last day of antibiotic. Yung reinfection meanwhile is due to a different bacteria, not the similar organism, which would be or it could be a previously isolated bacteria after a negative culture or an adequate period of more than 2 weeks between the infections. So, recurrent UTI, while some would say there could be a urologic abnormalities, routine screening based on the clinical practice guidelines is still not yet recommended. It is although advisable in these instances. No response to the appropriate antimicrobial therapy, gross hematuria during a UTI episode, or even a persistent microscopic hematuria, presence of obstruction, clinical impression of persistent infection, yung those with urea splitting bacteria such as Proteus, Morganella, and Providentia, history of pyelonephritis, symptoms that might be due to kidney stones, azotemia, and history of childhood UTI. So prophylaxis is given among these individuals so that they would decrease frequencies of recurrence. But we have to consider yung frequency and pattern of recurrences because this would be like a maintenance medication for them. You have to consider the lifestyle and the compliance, plus the willingness to commit to taking that medication. Is that particular female has a plan for pregnancy because there are antibiotics that won't be allowed once a patient gets pregnant. Antimicrobial resistance and susceptibility pattern, and the risk of adverse events and drug allergies. So, on top of that, behavioral measures can be important. The cleaning of anteroposteriorly. So, dapat palikod yung punas, no? Nung puwet, hindi paharap. Postcoital urination, liberal fluid intake, avoidance of tight-fitting underwear, and use alternative form of contraception that doesn't uh, um, using spermicide-containing contraceptives. Sorry. So these are some of the antibiotics for prophylaxis with the frequencies. And then there are some studies, although there is a low certainty of evidence that cranberry products are can also prevent recurrent UTI. But we have to there are certain brands that underwent studies, so not all cranberry supplement brands can be used. So you have to refer to the guidelines on what are these particular brand of cranberry which has proven to decrease the possibility of a repeat urinary tract infection. So these are the factors, or if it is present in the patient, which means they could be complicated. So ayan. So yan yung ano. So the word complicated is the abbreviation of those factors. So it is a significant bacteriuria plus clinical symptoms that occurring in presence of a functional or anatomic abnormality in the urinary tract or kidneys. There's an underlying disease that interferes with the defense mechanisms of the person, and those conditions that increase the risk of acquiring a persistent infection or failure of the treatment. So definitely, it's not just urinalysis that you have to request, but also gram stain, culture, and sensitivity before starting any antibiotic. And then other tests would depend on the risk factors that the patient have, the clinical history, and other comorbidities. Um, Definitely, you want to investigate the urinary tract because usually there are anatomic and structural abnormalities. So CT scan would be generally be preferred over KUB ultrasound because it can localize and identify more the urinary tract abnormalities or multiple lesions. So these are some of the antibiotics that can be used, so oral regimen or parenteral. So it can be treated outpatient, but if those patients have uh, severe weakness, compliance would be in question, the patient is already vomiting and is unable to take it orally, so you can also admit the patient and give it through the IV line parenterally. Finally, acute uncomplicated cystitis. So this would present with dysuria, frequency, hematuria, and more of hypogastric pain since it's confined to the bladder. For this one, you don't even need to use urinalysis or dipstick. As long as the symptoms are is there and it is a non-pregnant individual, you can already label the patient as having acute uncomplicated cystitis. So these are some of the medications that are used. So this is already based on the updated clinical practice guidelines. However, if the patient has flank pain, chills or dysuria, and fever, the patient might have acute uncomplicated pyelonephritis. So for this one, you have to request for a urinalysis, and probably eventually you need to also have a culture studies. So oral fluoroquinolones would be the antibiotic class that's preferred for acute uncomplicated pyelonephritis. So again, culture sensitivity should be performed prior to the antibiotics. So if this does not work, we can have other options, no, once the results of the culture comes out. So that's the two parts of the second Thursday of our discussion. So thank you for listening.